Good afternoon and welcome to Bariatric Friday. My name is Kemal Erkan. Today, we are going to have one of our new surgeons joining us, and we are going to discuss his journey with CRIAS and American Surgery Center. And I'm going to welcome Dr. Donovan Hui. And I know I'm going to work on the last name, so I'm going to get better. So, but what's the right way to say it?
Hoy,
Hui.
like
So,
ahoy, pirates.
okay, so I'm going to try that. Okay, so, and every time I don't say it right, so Ethan needs to tell me.
He owes me $1 each time.
Yeah.
Yeah.
Just so, well, again, welcome to the show and welcome to Delaware and CRIAS and American Surgery Center. So, if you can actually just tell us about your background and what led you to pursue a career in surgery so that we can start with that.
So I'm originally from Northern Virginia, and I did my college there, and then kind of transitioned there to go to medical school in Chicago. And when I was trying to decide what I wanted to do with the rest of my life, mom was like, "Don't be a doctor." So I was like, "All right, mom, I'm gonna be a doctor." She's actually a neonatologist. So I work with her and a lot of her pediatric colleagues a lot. And I was thinking actually pediatrics when I was in medical school. And the real impetus for that was in pediatrics, you take care of a patient and you take care of them for years plus, right? So that longevity of care is what really drew me to medicine. But then going through my rotations in medical school and doing surgery, there's such a profound impact we have as surgeons. You do a surgery and you can save lives so quickly, and there's such a long lasting impact from such a short interaction. I think that was very meaningful and impactful for me. So I kind of went down that route and I never looked.
So, and it's after medical school 4 years, it's 5 years residency,
Yes.
and then you did fellowship for
1 year.
one
Yeah.
year.
So it was 5 years in New York City, Manhattan, for my surgical residency, and then I did 1 year advanced GI bariatric MIS fellowship in University of Virginia.
So now the specifically in bariatric surgery, you did your fellowship, and what we know with the weight, the bariatric surgery is not just about weight loss, but it's also improving metabolic health and quality of life. So, uh, and there's so much impact that we see in people's life when they are able to lose a lot of weight, but also there's a lot of other benefits of it. So, what drew you specifically to bariatric surgery?
And that kind of ties in with my initial decision to go into medicine at all. And that was the longevity of care. Because ideally, you go to see a surgeon, you see a surgeon, and then you never see them again, right? They fix the problem. That's the ideal situation for some patients. But in bariatric world, there's a continuity of care there for the surgeon. So you see a patient, you work them up, you talk to them before surgery, months before, you plan a surgery after having gone through kind of a lot of hoops to jump through, honestly, but it builds a foundation with you and that patient such that you take that foundation and take it from month after surgery to 3 months to 6 months to a year and then yearly after that. And that's kind of a long-term connection that you have that most surgical specialties don't really have besides bariatrics.
You don't. You're absolutely right. So, staying on the training and experience a little bit. So, bariatric surgeons combine advanced laparoscopic and robotic techniques with evidence-based care. And if you can just elaborate your training and how it shaped your surgical approach. Um,
Yeah, so I think what you have to think about is what is best for patients, right? And the laparoscopic and robotic platforms are altogether kind of umbrellaed under a minimally invasive surgery.
mhm.
And that really promotes patients to recover faster and be more independent quickly after surgery. So we can do more extensive surgeries with smaller incisions and more precision, such that patients are up and about the day of surgery. Okay, as opposed to big open surgeries, long time to recover, a lot of pain issues, a lot of issues with pain control, medications, etc. We're opting now to do more advanced techniques that allow us to make smaller incisions and get our patients mobile again faster. And I think what really plays into my journey in general surgery and bariatric surgery is how that technology has continuously helped evolve our ability to do that. And within surgery, you can still do the same thing over and over again, but really testing the boundaries of how technology can play a role in the surgical suite and the operating room is, I think, very critical because we have to stay on top of things. We have to stay up to date. We have to stay relevant to our patients to get to a point where we can do surgery in a way that's very safe, but
Mhm.
using the best possible technologies. And that's kind of what melds our ability to make sure patients do well from the get go.
So as I'm listening to you, I am just kind of remembering some of the things that we went through in 2018 when we started our program in the surgery center in American Surgery Center. And although we are a 24-hour surgery center, we can keep patients overnight. And I thought that time it was always better for patients to stay in than just sending home. And with the right approach and right experience and right people on board, Dr. Irgao said like patients they recover the most and fastest when they're in their home. So it took a while for me to kind of get over this old habits and understanding of these things. And then, excuse me, we actually um, sent every patient home. Um, and there were only a few patients, excuse me, there were only a few patients we had to keep them overnight. And, when you tell someone who don't have experience with bariatric surgery, the idea is like, oh my God, like that's a big surgery. Well, it's not. Yes, it is an important surgery, but it's nothing more complex than gallbladder surgery. So in terms of the recovery and the way that you see someone in the morning and they spend about 6 to 8 hours after their operation and they go home. It's like when I'm in the surgery center, sometimes I see them and then they're already walking and they're smiling. I always smile, but I don't know why they are smiling. I would think that they are.
It's the anesthesia. It just makes them feel good.
Like you would think that they would be in pain, but no. Like they're actually happy that they're up, and so that's really kind of uh, make me understand that you know how we can actually best help these patients and make sure that they are in the right place with right techniques and also right nurse team. So in the surgery center, for example, because main surgeries we do is on bariatric and some general surgeries, obviously, our nurses they see the same type of surgeries and different patients, but same surgery all the time. So sometimes this is not the case in the hospital. So they actually they may be assigned to a different team, different so then their training is different. But with us, we have bariatric certified nurses, but also even if they don't have actual certification yet, they're seeing these every day, taking care of these patients. So and it helps for patients' recovery as well. So the techniques and the recovery and overall approach, I think it's all important for the bariatric patients. Now, the long-term success after bariatric surgery depends heavily on the support and education. Now, from the surgeon standpoint, how do you describe your philosophy when it comes to caring for bariatric patients?
I'm just a monkey with little instruments. That's all I'm doing. I think a lot of it has to do with empowering patients, kind of learn about what they're going through, what kind of surgery we're doing. It doesn't matter so much as it does having the patients understand what's going on with them, what changes are going to happen, and how they can best meet their goals in terms of why they want to lose weight in the first place. And a lot of that has to do with way before surgery, right? And that comes with meeting with dietitians, meeting with the endocrinologists, their primary care doctors, and understanding what their goals are and how they can get to that goal, and being very well aware
Mhm.
that um, the surgery isn't the end part of their journey. It's just the beginning, honestly,
Mhm.
and it doesn't happen with just us. And I'm a very small cog in that wheel because you need someone to constantly take care of you afterwards in terms of making sure that your diabetes is being well taken care of, you're adjusting your insulin doses, because oftentimes patients with morbid obesity, their diabetes significantly improves after weight loss surgery, right? So you need someone to kind of monitor that, make sure your insulin is dialed
Mhm.
in just right, and it's a very multidisciplinary need, multidisciplinary kind of group that is needed for taking care of these patients, because it's me as a surgeon, I'm just a very small part of that, and I think that it's an important part, and it's most important though is having the patient to be empowered to take care of themselves. So I think it takes a lot of hands, but my hands are only a very small part of
Well, I think you are being too humble with that. So I know, when patients talk to you guys, things changes. So from the consult to the surgery, I mean, they have a lot of respect and trust with the surgeons. So that's what I see with the patients, and I appreciate you being humble with this. But um, the role of surgeon is very big. So I'm not disagreeing with you, but I'm just saying that you are being a little bit too humble.
that.
So the because we see this with the patients when the primary care physicians are referring them. Sometimes they don't really follow through, and if we are able to get that patient into the surgical consults, understanding of what they have and what they need to go through and how important it is, it's a different ballgame.
Yeah. Well, the
So
idea of surgery is scary sometimes because
right, so
it's invasive.
no one wants to have a
Yeah.
surgery. You're right. So, but we know that these patients. So I'll tell you, one of the patients that our case conferences, I run those on a daily basis. So uh, I have a patient. Well, most patients they go through this process without a problem. But sometimes, with my own kind of like uh, whatever you want to call, sometimes I'm way too motivated to help. So I had a patient whose BMI was 72. This is November consult, and we need to bring this patient to BMI 60. She was a female patient, so 60 is the limit. And today she was over the 425 limit for the surgery center, and then still with 425 when she came to 425 she was still over 60 BMI. So I think today she was at 418 pounds. We started with 490 if I'm not mistaken. you know Getting that patient, working with this patient and not losing them in between. Nutritionists, they had 8 9 nutrition visits.
Mhm.
Like, this is not our typical patients, but sometimes what we have to do to keep them and make sure that they know that we believe them, but then also we kept a lot of surgical visits in between, so then they didn't lose touch with their surgeons. And today I think Dr. Noel did clear the patient from the surgery center standpoint, and I was extremely happy. So this is one of the things that makes this healthcare very special, because at the end of the day, it's not just business, but it is impacting someone's health. Now, imagine like bringing that person with all the habits that they have before the surgery, like almost 12 BMI points, was like a miracle. And patient was about to drop, and I personally called the patient several times, and now so we are almost at the end of it. So she should have her surgery sometime this month. Now, and surgeon is leading that, and I know you guys have a lot of training, and then in time there's a lot of cases done. So patients do follow you. So now, talk to me about the minimally invasive techniques a little bit. Last week with Dr. Picard, she explained some, but for those who may not really understand what we do under the minimally invasive and why this is more beneficial for the patient and outcome, we discussed a little bit, but if we can elaborate that a little bit.
Yeah. So surgery in and of itself is invasive. We're making incisions, we're cutting tissue, we're moving things around inside your abdomen or wherever we're operating, and that all creates inflammation. That creates, your body doesn't like that. Us kind of messing around.
Hmm.
So your body doesn't like that. So anytime we can minimize that inflammatory response, you're going to maximize your ability to recover quickly. So a minimally invasive technique involves either a laparoscopic or a robotic platform, and the robotic isn't autonomous. We
Hmm.
control the robot, but it's a platform in which we can use small incisions to operate in a bigger space. So within your abdomen, which is common for what we do, there are laparoscopic robotic techniques for things like thyroid, chest
Hmm.
surgery, heart surgery, lung surgery. But for majority of us in our group, we do a lot abdominal surgery.
Hmm.
So we make smaller incisions and we fill the belly with CO2, which allows us to see and insert a lot of small incisions. And the biggest one is typically about, I don't know, 15 millimeters. So
Very
half
small.
an inch,
Yep.
half an inch. Small incisions to kind of do an entire surgery, and it can be involving fixing a hiatal hernia, fixing abdominal wall hernias,
Hmm.
fixing um, how things are oriented in your abdomen, which we
Hmm.
can do for bariatric surgery. We can um, remove a portion of the stomach, and the stomach can get quite large. It's a big organ when it's fully distended, but we remove that through an incision this big. And those small incisions allow our patients to go home quicker, recover faster, kind of get back to normal living. And that's kind of the push for why minimally invasive surgery is so important, because one, it's cheaper, right? To be able to go home quicker. Your expenses in the hospital is significant when you have to stay in the hospital, right? If you go home the same day, then
Right.
your expenses are significantly less.
Yes.
It's
And
not just
also the risk of getting infection.
exactly.
The
So,
hospitals are not clean places.
well, the thing is, they're overly clean, so
Right.
they're inundated with how we clean everything, but because of that, we kind of leave only the super bacteria left, right? Super germs left,
Hmm.
and at that point, then you're at higher risk for infection being in the hospital for longer. You can go home and recover. I mean, I like my bed. I really like my bed. It's like a full, very big, right? Being in a hospital bed, it's small, it's cramped, it's uncomfortable. There's beeping everywhere.
Right.
So going home is paramount, and I think that's why the minimally invasive
Hmm.
laparoscopic or robotic techniques are very good in
Absolutely.
minimizing inflammation, minimizing damage we can do to the organs, and getting patients home faster.
Now, many people misunderstand what bariatric surgery is and who it is for. So, during your training and now you've been with us, what are some misconceptions you often encounter about bariatric surgery?
I think the biggest misconception is that bariatric surgery is like the golden ticket, like an easy way out to lose weight. It's not really that, because people think like, oh, I can get a surgery and I lose 50 pounds, 100 pounds, no problem, and it's quick and easy. It's not really. It's again, as I mentioned before, it's the start of a journey, right? And you start that journey like before you even see me, or and before you even get the surgery,
Hmm.
and it requires a lot of dedication on patients. To kind of think that this is a lifestyle. This is my life. This is the health I want. This is kind of my goals 5 years, 10 years, 20 years down the line, because that's ultimately why we're doing the surgery, is because we want to improve your overall health. We want to improve the energy you have, fix a lot of the comorbidities that may be associated with obesity, things like hypertension, depression, anxiety, these kind of derived diabetes, a lot of back pain, knee pain comes with that too. So a lot of those things can overall improve patients' health, but it's a journey. It's not like a quick snapshot. It's like not like I'm getting surgery. It's not an easy way out. By any means,
Hmm.
it's not an easy way out.
Right.
If you're gonna see me at least like 15 times, that's no way an easy, because I talk fast. I'm
Absolutely.
kind of a hard person to deal with,
Right.
right?
So, it's not for, again, it's not for everyone, right? So, we talk about our patients, the BMI average is about like 46 to 49. So, I don't think anyone in this room wants their BMI to be at that level. So, it's a different level that we are talking about. And again, as you mentioned, like, this is not just about morbid obesity, but because of morbid obesity, there's diabetes, there's sleep apnea, and there's depression. Even it goes to cancer, and for women, female patients, you know, the time for the menopause, how they are going through the menopause, how early they go through, how much weight they're going to gain. For younger patients, um, their puberty age is changing because of the morbid obesity, and this is just very complex altogether. And surgery is never the easy option, but most powerful one
It is
as
most
a
powerful.
tool.
Yeah, if you look at how, surgery compares to medications, compared to lifestyle modifications, all those things are important because they can all kind of work in synergy to help kind of
Mhm.
get you to where you want to be. But surgery has the most profound, long-lasting impact and the longevity in terms of weight loss options.
And the longevity is one of the things that we are looking for the most, and multidisciplinary collaboration, as you mentioned earlier, it helps to not just get the short-term outcome, but making sure that this can be long-term. Now, with CREAS, we work with United Medical ACO, and our multidisciplinary team includes our dietitians, our social workers these days, because social determinant of health is a problem. The Lieutenant Governor was in the program earlier, and if you don't have transportation for these patients, they're not able to make certain appointments. So, and our social workers are helping our primary care bariatrician, our nutritionists are extremely important. So this is just a lot of things that we do in this program, especially with our daily case conferences. People, our team meets on a daily basis. When I say this to many people, they think that I'm making this up, but I tell them just challenge me and then go to my schedule because they're all recorded meetings. So we meet every day, and then this is same for our ACO meeting, ACO case conference. So every day, 2 hours of my time is with our nurses and with our team. So, and we want this to stay with the patient. So that's why it's also important. And this is kind of maybe going to your earlier point about staying in touch with the patients. They will see you after the first year every year if they can have a annual check with the surgeon. That actually is very helpful. So, and definitely it's not an easy way out. Now let's talk about the future of bariatric surgery. And there's new techniques, data driven, and growing awareness of the metabolic health. Like, where do you see the field heading in the next several years?
It's hard to say. I think medication in the algorithm of how we treat obesity is definitely a major factor. Obviously, there's a big insurance play there, but end goal is that you want to understand why people are obese, and it's very complicated. It's not just because you're overeating, not just because you have an unhealthy lifestyle. It's a lot of things at play there, including psychosocial issues, environmental issues, genetic issues that all kind of play into why one obesity happened, or a patient may be obese, why that happened in the first place, and two, why it's so difficult to get that weight off with just
Mhm.
medication, with just lifestyle modification. So when we speak about what the future of bariatric surgery is, it's a little difficult to tell right now. Um, but so far, what we know is that surgery isn't going anywhere
Mhm.
because, if anything, we are actually reaching out to more people and having them feel more aware and more self confident that, like, hey, this is where I am. These are the options I can do, and surgery may be one of those options for me now that I've considered it, now that I've thought about it, now that it's
Mhm.
in the forefront. Then when we talk about techniques, there are a lot of different surgeries we can do for our patients.
Mhm.
There are sleeve gastrectomies, there are gastric bypasses, there are single anastomosis or or anastomosis duodenal switches. So these are all surgical techniques that have been developed for many, many years.
Mhm.
So there's only reason why we offer these to our patients is because we've vetted them. We said that this is an institution that can do these surgeries, that can do revisional surgeries because we do them safely, and they've done this for many, many years. So we can kind of tease with how we operate and how we rearrange their intestines to help lose weight. Ultimately, it comes down to how we can combine that with other avenues to find a way to help patients get to where they want to be, whether that's surgery and then medication, or medications only, or if it's a surgery then another surgery after that. Those are all very viable techniques, but it comes down to what kind of avenues we have in our brains, like thinking, all right, there's this path and this path and this path, instead of saying we only have one option. There's not just one option for one.
Right.
not just one option for every patient. It could
Absolutely.
vary.
They should have their choices.
Keeping that open mind is, I think, is very important.
Right.
How we take-
Right. So now, correct me if I'm wrong, but you also have a special interest on reflux, right?
Yes. So foregut, kind of hiatal hernia, reflux issues, is something I trained quite extensively at my last year in fellowship. So looking how I can treat reflux with
So
medications
for
and
those who
surgery.
may not know, like they may have it, but they don't know what the
Mhm.
term is. What's reflux? Like,
So reflux is essentially when the contents of the stomach don't want to stay there and they tend to go up into the esophagus. And that can be very dangerous because the lining of the stomach is different than the lining of the esophagus. And that's because the stomach is intended to hold and react to a very low pH, the acidity of your stomach, right? That acid taste that you may have when you have reflux, that's the acidity of the gastric or the stomach contents. When that kind of goes up into your chest, into your esophagus, it starts to irritate the esophagus, and that's that burning sensation that you have when it goes up into the esophagus. That heartburn, that's reflux. Okay, and the thing is that that's not all reflux can be, because what can happen is those changes, that inflammation, that heartburn you can have to your esophagus, that can change the esophagus lining itself. Because if that happens, that's precancerous. It can be very, very dangerous. So there are oftentimes medications that treat this. And for a person with reflux to see a surgeon, that usually means that their reflux has gone through many iterations of medications. Maybe the medication is not working for them. Maybe they need a different kind of medication, or maybe they need a combination of medications that will help them. But oftentimes when they see me at that point, it's usually very, very bad. So then we could offer a surgery to reduce the ability of your stomach to push up that acid into the esophagus, whether it's by fixing the little valve flap that kind of controls how things move from stomach to esophagus, whether it's a hiatal hernia where the stomach is physically up in your chest and kind of in the same space as your esophagus, or whether it's kind of maneuvering the stomach itself so we can prevent things from going up, is kind of the techniques we use to decrease your symptoms with reflux and decrease your risk for cancer.
I see. So my final question for you is the what message would you give to someone considering bariatric surgery but still unsure?
My door is always open. I think the important part is to start a conversation. You don't have to see a surgeon and get surgery, right? Seeing a surgeon to understand what the surgery is, I think is much more important than getting the surgery. Because I think this is bad for the business model. I'm just saying I saw a couple patients last couple weeks, and none of them wanted surgery, and that was fine. But I gave them the information. I gave them the opportunity to ask questions and educate them on how they can empower themselves, how they can make lifestyle modifications, and if and when they are thinking that surgery may be an option for them, they always know me. I know them now. That we can always continue that conversation from here.
Excellent. Well, thank you for joining us today.
For having me.
So we are proud to welcome Dr. Donovan Hui. Hui, did I say it right?
Yeah.
Hui. I wrote it down. So let's start again. We are proud to welcome Dr. Donovan Hui to CREAS and United Medical. His expertise and compassion will strengthen our mission to provide top quality, patient-centered bariatric and minimally invasive surgical care. And again, thank you for joining us today. And then we'll be back next week with Dr. Erkan. And until then, please stay united. Bye-bye.